training in clinical pharmacy at Shaukat Khanum Cancer Hospital in Pakistan. Dr. Mansour joined the Ministry of National Guard in 2006, and he's a board-certified oncology pharmacist. He's a keen member of several committees in the hospital, including the Pharmacy and Therapeutics Committee, and where he has a significant role in doing cost-effectiveness analysis and participating in decisions on cost-effective impact in the Ministry of National Guard Health Affairs. Dr. Mansour is heavily involved in teaching students, residents, and fellows in the hospital, as well as the university, where he is a clinical adjunct assistant professor. Dr. Mansour is involved in clinical research. He has more than 20 publications in peer-reviewed journals, and he established the Oncology Clinical Pharmacy Services in the Princess Noura Oncology Center in Jeddah. Dr. Mansour will be speaking to us today about the innovative therapies in CLL transforming patient care. Dr. Mansour, we're happy to have you. The floor is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to thank Dr. Osama Tabara, Dr. Ahmed Jadai, and Dr. Ahmed Al-Owaini for the invite to be speaker in this prestigious forum, and thank Dr. Anas for the nice introduction. Can I share my screen? Can I be allowed to share my screen? I think yes, I am. Can you see my screen?
Yes, doctor.
Okay, perfect. So I still remember, like 5 years ago, I was in one of the hematology meeting in Dubai, where a lot of hematology physicians from North America and Europe, they asked me a question. Actually, we were asking each other a question like, when can we enter a chemotherapy-free zone, and from where we can start? So they were actually suggesting that actually, at that point in time, FCR was the standard of care. Ibrutinib just made its way, and we were using it mainly for the 17p deletion, the high-risk mutation CLL patient. So they suggested that actually we can probably use it from the oil-rich countries such as Saudi Arabia and UAE. And I told them that actually it's not possible. I mean, it's so expensive. We didn't have the randomized control trial in non-17p deletion setting, in major patient population. So it's amazing that today I'm presenting the innovative therapy in CLL in a way which is transforming the patient care, and we are talking about chemotherapy-free zone globally. All over the world, we are using chemotherapy-free zone. This is the only disease where we are using a chemotherapy-free zone for the CLL. I don't have any disclosures. These are my objectives. Because of the paucity of time, I'll talk about mainly the first line treatment setting. So we'll talk about the first line treatment options in both 17p deletion and non-17p deletion untreated CLL patients based on the NCCN guidelines. And I think so there's going to be repetition of the slides, there's going to be a repetition of most of the content actually. I'll try to talk about the landmark trials which were the basis of the recommendation in the first line setting in the NCCN guideline. If we had time, we'll try to touch upon the second line, subsequent lines of therapy in CLL. And probably we'll try to talk about some of the trials for the second line setting, landmark trials for the second line setting, and we'll try to address the clinical pharmacology of the novel therapies used in CLL. So let's move to the first line therapy in CLL. I think Dr. Hammam has covered the basic biology and pathophysiology of the disease, and it took the whole journey very well in a fabulous way. Thank you so much, Dr. Hammam, for making my life easy. But when we are selecting the therapies in the first line untreated CLL patient, two important parameters we have to consider. In the past, we have been considering the staging system, like RISE staging was quite common. Stage 0, which varies from stage 0 to stage 4, but that didn't have any impact in predicting the survival outcome. But now we have the genomic parameters, we have the prognostic markers such as cytogenetic abnormalities, which can help us in in selection of the different therapies in the first-line setting. For example, we have deletion 11q, which is associated with unfavorable outcome, and that's associated with significant lymphadenopathy and shorter disease-free survival, and that's known to be responding to alkylators and fludarabine-based therapy. And similarly, deletion 17p is one of the worst outcome that we see in patients those who have the deletion 17p, and that reflects the loss of the key suppressor gene, which is considered the genome of the guardian, basically. And these patients have very shorter overall survival, shorter progression-free survival, and shorter disease-free survival. And then we have IGHV mutation, the patient, those who have mutation, that they have favorable outcome, and those who do not have the IGHV mutation, they have unfavorable outcome. The reason the patient, those who have favorable outcome in IGHV mutated patient, is that it reflects that the clonal evolution and the expansion of the CLL has already happened, and it's not gonna progress down the line. Whereas those patients who have not mutated, whose IGHV is not mutated, they can progress at any time down the road. And then the second point that helps us in selection of the options is the performance status of the patient. So there is one famous CLL group who talked about 3 different categories called go-go, slow-go, and no-go patient, which is not seen in NCCN guidelines. However, it's actually mentioned in all the CLL conferences. It's mentioned again and again all over. So basically go-go patients are young, physiologically fit patient, less than 65 years of age, and having no comorbidities, and they can tolerate intensive therapies. Whereas no-go patients are frail patients, more than 65 years of age. As Dr. Kumar mentioned, the median age of the CLL is 72 years or 71 years. And these patients have lots of comorbidities, so these are no-go patients. And then the slow-go patients are in the middle, who may be less than 65 or more than 65, and who may or may not have the comorbidities or some comorbidities, but they would like to desire intensive therapy. So in my talk, I'll be talking about these 3 terminologies: go-go, slow-go, and no-go patients, and I'll be describing different trials. So here we go. Dr. Hammam talked about this. So the NCCN guideline basically categorizing, classifying the treatment options into 2 groups. The first group is no-go and slow-go patients, which are frail patients. And you can see the chemoimmunotherapy is not existing here. So it's alphabetically arranged treatment options. So we have BTKI like Acalabrutinib plus minus Otinutuzumab, and I'll talk about the landmark trial for that, in order to address one of the questions which was asked to Dr. Hammam. So yes, we have evidence. We have the randomized controlled trial where the BTKI, second generation BTKI, can be used. We have enough evidence. And then we have Ibrutinib, the famous first generation BTKI as a monotherapy. And then we have Venetoclax in combination with Obinutuzumab, which is fixed duration for 1 year. And that if somebody does not want to continue treatment for more than a year, this is a very reasonable option for those kind of patients. And then we have go-go patients who are physiologically fit patient, and for them the options are absolutely the same. There's no big difference, with an exception of Venetoclax and Obinutuzumab, which is still preferred regimen, but it has been downgraded to category 2A. And then we have IGHV mutated patients where Dr. Mem talked about FCR, and that's preferred regimen. But I was describing ECOG, one of the ECOG trial, where the Ibrutinib based regimens were compared with FCR, and we have seen there's no difference in the progression-free survival in patients having IGHV mutation. So we can still use Ibrutinib for patients having IGHV mutation because they are equivalent to FCR. So we are probably have entered completely chemotherapy-free zone. That's what we have learned from here. And those patients who have received chemoimmunotherapy and they have still residual monoclonal disease having detectable MRD. So these are the patients who actually can be a candidate for lenalidomide, which is category 2A recommendation based on one of the German CLL M1 study. Now let's move to the landmark trial, which were the basis of the recommendation in the NCCN guidelines. And the first trial is the RESONATE-2 study, where the Ibrutinib was actually compared with the chlorambucil, and patients were randomized to receive untreated CLL patients were randomized to receive either Ibrutinib or chlorambucil, and the crossover was allowed. The primary endpoint was the progression-free survival, and the secondary outcomes with overall survival, overall response rates, and the safety. And you can see the clear separation of the curves between the ibrutinib arm and the chlorambucil, and the progression-free survival was significantly better with ibrutinib in comparison to chlorambucil. And overall survival at 60 months was significantly better again. No surprises in the favor of ibrutinib versus the chlorambucil 68%. As a result of this study, we have seen the recommendation, the impact on the NCCN guidelines. NCCN guideline recommended ibrutinib to be approved in the first-line setting in CLL. Then we had the second study, which is Alliance A041202 study, randomized phase 3 controlled trial, where the patients were randomized in 1:1:1 ratio untreated CLL patient to receive either BR, chemoimmunotherapy, or ibrutinib alone, or ibrutinib in combination with rituximab. And again, primary endpoint was the progression-free survival. And you can have a look at the differences, the curves separating well separated from each other. Ibrutinib-containing regimens are significantly superior, no surprises again, in comparison to chemoimmunotherapy. The progression-free survival at 2 years was 87%, and that was similar to the ibrutinib plus rituximab, and that's an argument. That's why NCCN guidelines would like to recommend using ibrutinib as a monotherapy, as a preferred regimen in category 1, with category 1 recommendation, versus BR was 74%. Whereas there was no difference in terms of overall survival at 2 years, and someone can argue that 2 years is not enough time to evaluate the overall survival for a disease which is indolent like CLL, and as well as the crossover design might have an impact because the patient, those who progressed on BR, they were allowed to cross over to ibrutinib-containing regimens. Or I would like to have your attention here on some of the small groups, those patients who have ZAP70 unmethylated disease. You can see the ibrutinib in combination with rituximab actually performed worse than in comparison to ibrutinib alone. And as well as in high-risk disease, ibrutinib in combination with rituximab did perform worse in comparison to ibrutinib alone. So we're not comparing with BR, we're comparing ibrutinib versus ibrutinib plus rituximab. So that means that ibrutinib alone was as good as ibrutinib plus rituximab, and in some subgroups, ibrutinib rituximab performed worse. So based on that, NCCN has recommended to use ibrutinib as a monotherapy in both go-go and slow-go patient as a category 1 recommended treatment option with the preferred regimen category. The third trial is ECOG-E1912 trial, and that was the trial I was referring to with the IGHV mutated patients. This was randomized phase 3 controlled trial, and the patients were randomized in 1:1 ratio to receive either ibrutinib in combination with rituximab versus FCR. And the patient with 17p deletion were excluded from the trial because of the knowledge that they respond very poorly to FCR. So ethically, it was wrong to include 17p deletion patients in chemoimmunotherapy. The primary endpoint was the progression-free survival, and you can see the clear separation of the curves. Again, no surprises in the favor of ibrutinib rituximab versus chemoimmunotherapy. The progression-free survival at 3 years was 90% versus 72%, and in the second column, you can see the subgroup who had IGHV unmutated CLL patient, which is high-risk group. And in this group of patients, ibrutinib rituximab performed equally similar to the ITT population. So it was superior to chemoimmunotherapy again. And overall survival in ITT population was also superior in ibrutinib and rituximab. And here you can see the subgroup that I wanted to show you, that those patients who had IGHV mutation, there was no difference between ibrutinib rituximab versus the FCR. So that's an argument. Now I can do what anybody can do, that now we have evidence from this ECOG-1912 study that ibrutinib, when used alone or in combination with rituximab, can perform equally similar to what we had seen before with FCR. So the progression-free survival was similar across the both groups, 88% versus 88% in FCR. And those patients who had who had IGHV unmutated disease, which is high-risk disease, ibrutinib performed significantly better than the chemoimmunotherapy. So based on this trial, the NCCN believed that based on the finding of the previous trial, like Resonate 2 trial and the Alliance trial, they continued with the same recommendation of category 1 recommended option for both no-go, slow-go, and go-go patients. Then move to the Acalabrutinib. I think somebody asked this question in the chat box. Do we have evidence for second generation BTKI for the use in untreated CLL patients? Yes, we have the evidence, and that's Acalabrutinib. It was actually evaluated in ELEVATE-TN trial with and without obinutuzumab, and was compared with chlorambucil and obinutuzumab. So in this trial, which was randomized phase 3 control trial, patients were randomized in 1:1:1 ratio to receive either Acalabrutinib monotherapy or Acalabrutinib in combination with one of the anti-CD20 monoclonal antibody of obinutuzumab or chlorambucil plus obinutuzumab. And the crossover to Acalabrutinib was allowed, and that's ethically right, because the patient who can actually progress on obinutuzumab, chlorambucil, they can have a choice to go to Acalabrutinib or Acalabrutinib in combination with obinutuzumab. And the primary endpoint was a progression-free survival, and here you can see the differences and the outcomes that were measured. No surprises. Progression-free survival at 30 months was significantly better in Acalabrutinib containing regimen versus the chlorambucil plus obinutuzumab. And overall survival, there was no difference in 3 groups, and I can give like a couple of reasons for that. Like 30 months again is not enough time to evaluate overall survival for a disease like CLL, and the crossover design probably might have impacted the overall survival outcome. And moving to the summary slide of the ELEVATE-TN study, the NCCN recommended Acalabrutinib alone or in combination with obinutuzumab as category 1 preferred regimen for all group patients, go-go, no-go, and slow-go patients. Then we have the CLL14 study. Many people actually like this regimen because this is given over 1 year. It's a fixed duration. So in this study, basically randomized phase 3 control trial, patients were given Venetoclax Obinutuzumab, and the other group was given chlorambucil plus obinutuzumab for a fixed duration of 12 cycles, and each cycle was 28 days. And the crossover was not allowed in this group of patients, and the primary endpoint was the progression-free survival. And all the outcomes that were measured, no surprises, Venetoclax and obinutuzumab was the hands-down winner over chlorambucil obinutuzumab. Progression-free survival at 24 months, and any responses to treatment, and for the first time, minimum residual disease was reported to be significantly superior 3 months after finishing treatment, was 75%, more than double actually, versus 35%. So based on the CLL4 study conclusion, the NCCN guideline have recommended to include Venetoclax in combination with obinutuzumab as preferred regimen with category 1 recommended treatment option for all go-go, no-go, and slow-go patients. So now move to the first-line therapy in patients having the 17p deletion or TP53 mutation. So previously we've been talking about those patients who do not have 17p deletion. Now we're talking about those who have 17p deletion, which is a high-risk disease. So the preferred regimens are very similar to what we have seen before, but the only difference is that they are preferred, but they are recommended with category 2A recommendation. And those patients who actually do not tolerate the first and second generation BTKI, you have an option to go to Venetoclax. But if there is a resistance due to mediated by the BTK481S mutation, then we have to change the BTKI therapy to something else. The first audience response question, I'm not sure whether I'm going to, I think this is for Kahoot. Now, moving to the pharmacology, clinical pharmacology of the novel agents that we are discussing today in the CLL management. So CLL is a B cell problem. So B cell is CD20 positive malignancy. So we have to talk about, and we have to give this patient anti-CD20 monoclonal antibodies. There are 3 of them, and I'm showing here 2. The first one is obinutuzumab. The second one is rituximab. Both of them are similar in terms of having their mechanism of action. They both work on the CD20, and they both work by ADCC effect. However, the ADCC effect of the obinutuzumab is much more potent in comparison to rituximab. However, rituximab had an advantage over obinutuzumab that it has more complement-mediated cytotoxicity. However, for the management of the malignancy, most of the most of the effect is actually mediated by ADCC. So obinutuzumab is much more potent anti-CD20 monoclonal antibody for CLL, but I don't believe that for follicular lymphoma. So at any point in time, IVPN webinar, and it is a conference for the follicular lymphoma, so I'll be talking in the favor of rituximab. We have other forms of the rituximab in CLL, like subcutaneous rituximab, 1600 milligram fixed dose. It's given over 5 to 7 minutes, and it saves infusions and a lot of time. It's not approved by Saudi FDA. It's not available in our hospital and other hospitals in the country in Saudi Arabia. We have biosimilar rituximab right now. There are 5 different brands of the biosimilar rituximab approved by international regulators, and NCCN guidelines have a recommendation for the approved biosimilars of the rituximab and others that an FDA approved biosimilar is an appropriate substitution for all rituximab indications. So likewise, Saudi FDA had approved biosimilar of rituximab, which is Truxima, and Ministry of National Guard Health Affairs has added biosimilar rituximab recently as a cost-containing or cost-saving strategy. We have kept the rituximab subcutaneous, but for other diseases like lymphoma and etc. Biosimilar rituximab will be used for CLL, for ALL, and etc. for inpatient purposes of the rituximab. I think Dr. Hamam talked about this study, the targets that we're going to work on. So we're going to move to the BTKI. Pharmacology, clinical pharmacology of the BTKI. So here you see the 3 different BTKIs. We have ibrutinib, we have Acalabrutinib, and we have Venetoclax. So BTK, which is Bruton's tyrosine kinase, and is an important integral component of the B cell receptors pathways. So when the B cell receptor pathways are activated by the Bruton tyrosine kinase, this results in survival and proliferation of the malignant B lymphocytes. Inhibition of this BTKI signaling, BCR signaling, results in inhibition of the proliferation and survival of the malignant B lymphocytes. Acalabrutinib is pretty similar to this with the mechanism of action, however, it's more selective, and probably it might have less toxicities. And zanubrutinib is similar to others, but it is highly selective BTKI and has lesser toxicities in comparison to others. All ibrutinib, acalabrutinib, and zanubrutinib are given once daily. Ibrutinib is used once daily, and acalabrutinib and zanubrutinib are used twice daily. All of them are approved in first line as well as in second line setting. One of the things that I would like to point out here is the lymphocytosis that we see after starting therapy for the CLL, especially with the small molecules. So what happens when we start, because the malignant lymphocytes are trapped in the lymph nodes when we start therapy. So these BTKIs and other BCL2 inhibitors, what they do basically, they inhibit CXCR4, CXCR5, like we have seen the plerixafor, and they do the trafficking of these lymphocytes, and the lymphocytes are actually migrated from the lymph node from other areas to the peripheral blood, and we see transient increase in absolute lymphocyte count, and we have to tell a patient that's not a sign of progression. With regards to the adverse effect, I think all BTKIs, they share the same side effects like bleeding, new onset atrial fibrillation, and hypertension. And with the acalabrutinib, headache was also reported. And with zanubrutinib, there are some other mild toxicities. With regards to the resistance, that's an important point that I would like to make. In the whole Middle East, we don't have in-house mutation for the CLL patient. We don't have the mutation panel to be done in the country. We don't have in-house facilities for the Bruton's tyrosine kinase and PLCG2 mutations in the country as well as in the Middle East. I think Dr. Ahmed Al-Jadai is here, so I'd like to convey this message to him that I think we should have in-house BTK mutation testing for our patients, because these patients are staying on therapy for a longer period of time, and actually if you can test them for the mutation, you can actually predict their progression, because one of the most commonest mutation, the driver mutation, is BTK481 mutation, which has been acquired mutation on the use of ibrutinib. And if you do in those patients who have like select subset of patients, those who have minimum residual disease detectable, so those are the patients who are suspected to have progression. So if you, those patients, if you can do the mutation, so you can suspect the progression up to somewhere 9 to 15 months. And if in case of acalabrutinib, you can predict it if the BTK481 mutation is positive like 12 months before the clinical relapse. And in case of BTK481 mutation, if you remember, like BCR-ABL mutation, T315I mutation, which was resistant to all TKIs except the ponatinib, so it's similar to that kind of mutation. And it's resistant to zenobrutinib. But we don't know that the patient, those who stays on zenobrutinib, we don't have enough data whether they develop this acquired mutation or not. There are lots of drug-drug interactions. So as a pharmacist, as a clinical pharmacist, my job is to review the patient medication profile and change the medication if they're on strong CYP3A inhibitors or inducers. And if I cannot do that, then I have to reduce the dose of the ibrutinib. Similarly, they have interactions with the PPIs, particularly acalabrutinib, but ibrutinib and zenobrutinib doesn't have that. Ibrutinib and acalabrutinib are registered in the country with the price of ibrutinib $38,000 per month, and acalabrutinib is slightly cheaper than that. It's $28,000 per month. I always talk about the cost because I sit in the committees and I talk about the cost effectiveness. You can use acalabrutinib as a monotherapy. So in that case, acalabrutinib will be much more cheaper than ibrutinib. But if you use it in combination with obinutuzumab, and then you're going to offset the difference of this price in with the obinutuzumab. Now we move to the BCL2 inhibitors.
Can you kindly conclude in 3 minutes, please? Okay.
The BCL2 inhibitors. Venetoclax, people talked about the TLS. Yes, it's one of the agents that I never imagined that CLL patient can actually lyse and have TLS. But believe me, the first patient that we started with 20 milligram, patient actually had significant tumor lysis, clinical and laboratory tumor lysis. We had to give the patient their few kids and stuff like that. And after that, we're always admitting the patient with a ramp up. You can do this accelerated ramp up, but you can do the slow ramp up over 4 weeks as well. Same issue of the drug-drug interaction, etc. And that's the slide in the NCCN, which talks about the differences. Then we have the Idelalisib and Duvelisib. One of the things that I would like to touch for Idelalisib and Duvelisib, like I have a patient today in my clinic, and we admitted the patient. This patient has Crohn's disease, so we were thinking about Idelalisib-based therapy. But actually, because of the Crohn's disease, it's contraindication. One of the side effects that you see with the Idelalisib is very severe colitis and diarrhea, which is similar to graft versus host disease of the gut. So those are the kind of patients who are not a candidate for Idelalisib. Drug-drug interaction is the same issue. In the second line setting, you have seen this slide with Dr. Namer. So basically, you can use the same kind of regimens with an addition of PI3K inhibitors in first and second line setting. And I would like to talk about only a MURANO study here, which is fixed duration for 2 years, and there is a 5 years follow-up data presented here, Venetoclax Rituximab versus BR, and the 5 years progression-free survival was 53 months, and 5 years overall survival was 82%, which is significantly better than the BR. We have the landmark trials for Acalabrutinib, which is called ASCENT trial in the second line setting as well. Somebody asked the question, do we have the evidence of use of Acalabrutinib? Yes, we do have the evidence in first line as well as in the second line. I think Dr. Ahmed Al-Huwaini and the group can share my slides with people. And moving to the conclusion part, is the second audience response question. So the first choice of therapy in untreated patient, it depends on the cytogenetic abnormalities and the prognostic markers. And we can choose actually all novel agents in first-line therapies, including IDH mutated patients. We have an option to choose ibrutinib versus FCR. They're pretty much similar. One of the things that I would like to convey this as a message that we should ask for BTK mutation. Our referral lab in Europe also does not have this facility to do it for us. So Dr. Ahmed Al-Jadai and other leaders in the region, Dr. Anas, and you guys need to ask for BTK mutation, particularly 481 mutation, for serving our CLL patient in a better way. And I think we have completely transformed in the new era, which is called chemotherapy-free zone in CLL. And that's really an innovative era that we are in right now. Thank you so much for your attention.
Thank you very much, Dr. Mansour, for the comprehensive presentation. I know it's a very rich topic, but we're just trying to stick to the time. So sorry for the interruption. I have so many questions, to be honest. All of them are very nice questions. We'll try to tackle as much as possible. So I'll start with a question from Diya Yasser. He says, how does mutated IGHV is favorable in CLL?
Okay, I explained this. If IGHV is mutated, that means the clonal expansion of the disease has already happened. The disease has already evoluted. So this patient is not going to progress anywhere soon down the road. In case if the patient is not IGHV mutated, we don't know. We can't predict this patient after how long he's going to progress. So that's the reason. So the biology behind that is that the disease, which is IGHV mutated, has already evoluted. Expansion has already happened. The patient has already progressed.
Thank you. I have 3 questions, and all are around the role of CAR-T and gene therapy in CLL.
Actually, I would not like to comment on that. It's too early. NCCN guidelines have not considered the note of that. I think it's too early to talk about CAR T cell. We can talk about CAR T cell for lymphoma, for leukemia, for myeloma, for others, but CLL is too early.
Okay, one more question is about your experience on MRD negativity rebound after 1 year of Venetoclax treatment.
Yes, it can happen. Exactly, I don't remember the data right now, but with Venetoclax, I think the rebound is lesser in comparison to the comparator arm. So all the arm that has been compared with the chemoimmunotherapy or chlorambucil in combination with obinutuzumab, the rebound MRD is of course lesser, no surprises. It's much more lesser in the Venetoclax study. In MURANO study, the rebound MRD is much more lesser with the Venetoclax containing regimens.
As we know, PI3 kinase inhibitors don't do very well in the